Well, hello everybody. I'm not quite sure if we're live on YouTube. We should be, but at the moment it looks like we're not live on YouTube. So you can just bear with me a second while I jump across and explore what kind of technical problems we might be having. No, I think we are there. Okay, well, hello and welcome to this special live podcast from Dementia Researcher in association with the Alzheimer's Association. I'm Adam Smith, I'm the Programme Director, and here today to bring you something a little bit different. We're coming together to reflect on some of the outstanding plenary talks from this year's Alzheimer's Association International Conference, or what you'll probably hear us refer to it for the rest of the show is the AAIC, which took place in Toronto from the 27th to the 31st of July, just what feels like ages ago, but it's just a few short weeks ago. We're recording live today, and we're on YouTube, and we're also in the Dementia Researcher Community app. And today I'm joined by a brilliant group of ISTAART ambassadors from around the world who will each be summarizing one of the plenary talks and sharing your thoughts. And we do appear to be having our fair share of technical gremlins. Since we started, one of our speakers hasn't been able to join. Another one appears to have just disappeared. Hopefully they'll be back. If not, we'll be talking about fewer of the plenary talks than planned, but hopefully not. Our guests today are Jinhak Kim. We have Xue-Rui Peng, Nikitha Shiva Kumar, Vita Mithi, Ziphozihle Ntwatwa, and Ireneaus Nyame. And I got all those names completely wrong, and I completely apologize. But instead of me trying to get them right, why don't we do some proper introductions and let them pronounce their own names? But thank you all so much for being here, everybody. Z, why don't you go first and introduce yourself?
Oh, thank you so much for having me, Adam. Hi, everybody. It's so nice to be with you all. My name is Ziphozihle Ntwatwa. I am a Race Against Dementia Fellow in my postdoc on a study at the University of Cape Town, which explores mechanisms of neuroinflammation in Alzheimer's disease pathology in people living with HIV and those without. Thank you so much for having me.
Brilliant. Thank you very much. And why don't we go to Xue-Rui next?
Yes, so hello everyone, I'm Xue-Rui. I'm a research assistant at Southwest University in China and also a final year PhD student at Dresden University of Technology in Germany. My research focuses on the cognitive neuroscience of aging. I use neuroimage methods such as MEG, EEG, FNIRS, and fMRI combined with behavioral experiments to study the effect of aging on decision-making, perceptual memory, and how sleep influences cognitive processes. Thanks for having me.
Fantastic. That's exciting. Last year of your PhD is always a busy time. So thank you so much for taking time out to join us today. And let's go to Jin next. Hi, Jin.
Hi, Adam. Thank you for inviting me to this great program. My name is Jinhak Kim, and I'm a psychiatry resident and also a graduate student in Yonsei University. And right now I'm doing preclinical study with Alzheimer dementia mice, and also doing some blood-based biomarker study with human samples. Thank you.
Wonderful. Thank you very much. And last of all, we have Ireneaus.
Hi everyone, I'm Ireneaus Nyame. I'm from Ghana. I'm currently a research assistant at the University of Cape Coast, and currently I'm researching into sleep and then gas microbiome and then their interaction in cognition. Thank you very much for having me.
Thank you very much. So, well, we are here thank you all for joining us. So in this show, as I mentioned at the start, we're going to be covering the plenary talks, or some of the plenary talks that were presented at this year's AAIC. They range from biomarkers to sleep to tau pathology, gut-brain axis. There was a talk on Down syndrome, prevention, resilience, and so many more. Of course, we have already recorded a few highlights podcasts where these might have been mentioned already, which you can go find on YouTube or in your podcast app as well. But what we're going to do today is get a little bit more into the detail of those. And to prepare for this, each of our wonderful guests has gone away and watched the talks again. And they're each going to give us a short summary of the plenaries that they've watched and enjoyed. And then what we're going to do is we're going to have a chat about each of those and get some reflections, and we'd love your comments as well, so do feel free to post a comment in the chat in whichever platform you're watching in. And our first one, Jin is going to summarize. So in this first segment, we're going to talk about Sylvia Villeneuve, who gave a talk on biomarker and clinical trajectories of preclinical Alzheimer's. And Sylvia's from McGill, and they spoke about about clinical trajectories, biomarkers. And Jinhak, you're going to lead us through this one, Jin.
Yep. Thank you.
Would you like to take it away? Let's hear about this talk, this plenary.
Yeah. So I have a short summary about this plenary. So Dr. Villeneuve's talk really emphasized that preclinical AD is not a uniform stage, but a dynamic process. And she gave a brief history of how diagnostic criteria and research methods was developed. And she walked us through how biomarkers evolve over time, starting from amyloid accumulation, tau, and then structural and functional brain changes. What stood out is that even when people look clinically normal, when they take amyloid PET testing, subtle cognitive shifts are already detectable if you use the right sensitive tools. And she also highlighted that not everyone with amyloid positivity progress the same way, and factors like APOE status, vascular health, and age, sex can shape the trajectory. And this has also connection with our following plenary lecture with Dr. Livingston's paper.
Wonderful. And what do you think were the kind of key take-home message for researchers who weren't in the room from that talk?
Okay, I say the key message is this. We need to think of preclinical AD as a very heterogeneous concept. And by looking at people's biomarker trajectories, amyloid, tau, imaging, genetics all together, we can build a much clearer picture of who is actually at risk and when they're mostly likely to decline. And that's exactly why a personalized precision medicine is becoming more important.
And do you think that's going to be, I mean, where do you think the major impact of that is going to be? Is that going to be in future drug trials, do you think? Or are these preclinical stages early enough that you could potentially, divert the course of the disease, do you think? Did you get any indication from the talk on that?
Yeah, so for early stage trials, I think we should select participants using multimodal trajectories rather than just amyloid PET or CSF alone, and aim to intervene before tau pathology is widespread, and use sensitive endpoints, including digital tools, to detect and change and screen larger populations more efficiently.
And so does tau, I'm to be quite honest, I've been in this field for quite a long time. I didn't really entirely realize. So tau, obviously, we know follows amyloid. And so you think that's a key stage between amyloid and tau is the key way. Are we able to detect early enough at that stage? Because amyloid is present so often in people that don't go on to develop tau. Was there any indication from the talk about those stages?
So in the talk, she mentioned about there are this is a very heterogeneous group, and how there's A positive, T negative, and A positive and T positive, and also A negative, and so like late pathology, where AT is both negative, and A is negative, T is positive, and there is very steep cognitive decline. And she didn't mention much about digital tools, but I've seen from other lectures where they are trying to find right tool to detect people even when before amyloid accumulations. So digital and then amyloid accumulation and then tau.
Yeah,
So,
and there are so many incredible developments in that space at the moment, aren't there? We did a podcast quite a while ago, probably 12 months ago now, looking at how some adaptive technology can be added to optometrists' eyesight checking machines. So as part of your routine eye exam, you could have a review of amyloid levels using machine learning then on top of the scan which could then, because I think most people have an eye test fairly regularly, more so than they do hearing it tests or other medical tests and interventions. Fantastic. Z, I think you saw this talk as well, didn't you? You were following this one closely. Was there anything we've missed or that stood out to you in that, maybe in that broader theme about resilience?
Yeah, I just want to take a step back. I mean, this was quite a special session because it was the opening session of the conference, and so we were able to witness quite a lot of special moments. And I think one of them that stood out for me was when Clifford Jack got his Lifetime Achievement Award for his the Jack curve, so recognizable representation of disease progression and Alzheimer's disease pathology. That was quite incredible to see. And I think the session then echoed what was shared in the beginning, which was the importance of longitudinal studies and capitalizing on the silent window. And by the silent, referring to the period when you have amyloid buildup and tau buildup, but people don't actually have any cognitive impairment, or rather symptoms of cognitive impairment, and using this window as a way of being able to profile people and trying to have interventions for perhaps people that might be I think in the session they sort of stratify, as Jin was saying, whether people are amyloid positive or amyloid and tau positive, or amyloid positive and tau negative. And the stratification was quite important. And I think what they showed, or at least what Prevent AD was trying to show, was that the presence of amyloid and the presence of tau together in that scenario, about half of the population that had that, who were cognitively normal, then ended up going on to having some cognitive impairment. But it's the other way around when it's you're amyloid positive but you're tau negative. Only about 9% of those people ended up with cognitive impairment. So I think what it was sort of suggesting and showing the role of having both of those biomarkers present, and where tau plays in the story. And it was quite interesting because nobody was just tau positive alone, right? So it's sort of this relationship between amyloid and tau that was standing out the most.
Which is interesting then, isn't it? In so much as is that the direction we'll take with, obviously, most of the drugs that we hear about in the news at the moment are reducing amyloid. But I know that there's a new generation of new treatments coming along to look at tau as well, aren't they? That's the new hot area, which I'm guessing we've got the CTAD conference coming up in December in San Diego. It wouldn't surprise me if we see more on those tau treatments at that event. Thank you very much. That was brilliant. So that's our first segment done. And we'll move on to our next. And let me hope that our speaker for this one is here. Yeah. This time we're going to talk about Katerina Akassoglou talk on neurovascular interactions in Alzheimer's disease. And Jin, is this you again? Or have I made a mistake?
Yeah, that's me again.
Sorry, I'm putting you on the spot twice and ago. So Katerina is from UCSF, and they presented on neurovascular interactions in Alzheimer's disease. So you're going to bring us this one summary. Let's go through it, Jin.
Okay, so this plenary highlighted how neurovascular unit, particularly BBB dysfunction, plays a critical role in Alzheimer's and other neurological disorders. And she showed that when this barrier breaks down, fibrinogen leaks into the brain, binds to microglia, and sets off cascade of neuroinflammation, synaptic loss, and ultimately cognitive decline. And what stood out to me most about this talk was that how she systematically approached this, identifying fibrinogen as a key driver and testing it in animal models and human studies, and ultimately establishing it as a druggable target. And this was very clear example of how translational science with real potential to change how we think about treating Alzheimer's disease.
Were there any particular mechanisms or treatment strategies that seemed more promising?
Yes, one of the most promising one was her lab work, product of her lab work, which was fibrin targeting immunotherapy. And given with the rapid growth of amyloid immunotherapy, the idea of combining these two strategies, I thought it was very exciting. And I think combination immunotherapies could really be promising path forward. And I'm really excited to see how it might reshape the treatment landscape in the coming years.
Immunotherapies are interesting, aren't they? I mean, they've been so transformational in cancer treatments in the last few years that you always hope. I think particularly during the pandemic, I hoped that lots of dementia researchers would jump onto those online conferences for other diseases for a little bit of inspiration or just some new ideas to look at things. Because I think all too often we don't necessarily do that. We kind of all go to Alzheimer's conferences or vascular, whatever is your thing. I think it's great to, when the time allows, to step outside and look at some of those other diseases and treatment areas for some inspiration, because some are ahead. See, I think you went to this. Were you covering this one as well? Again, I'm sorry, I haven't got my sequencing of this very good.
No, it's okay. I think what I've sort of taken, from this session is that, in the beginning, I was thinking of it in the line of like comorbidity when I think about vascular issues, but I think it kind of pushed me towards, seeing vascular issues as drivers and amplifiers within the system through, blood-brain barrier stress or impaired clearance, around the vessels. And I think what rather like needs to be, thought of or done, and I think the vascular space has done this quite well, is being able to, profile people according to their biomarkers, for example, and seeing who is low, or at risk, and then being able to start interventions for people that are already at risk. So we're talking neuroimaging biomarkers, CSF biomarkers, plasma biomarkers, and being able to stratify people and say, okay, well, this individual, possesses some risk, and perhaps we could start interventions now rather than waiting for a catastrophe in the brain and then only starting any intervention.
And so we're going to be running a series of debates in October and November on the dementia researcher community. And we asked the researchers to suggest topics. And one of them said, controversially, that we believe vascular movements are the anti-opial causes of Alzheimer's disease as something to debate. Unfortunately, I didn't have anybody willing to debate in favor of that, only somebody willing to debate against. So that hasn't made it onto the final list. But it is a hot topic, and we do see increasingly people moving between stroke research. I mean, the UK DRI has just opened up its whole new element, which is funded by the Stroke Association, the British Heart Foundation as well. So that those connections are increasingly being looked at. aren't they? And we've got Nikita back. Hi. Hopefully you're here to stay. Hi, Nikita. Let's see. Well, thank you very much, Jin and Z, for summarising that talk by Katerina. I take the opportunity to mention that, of course, we're only giving you a little summary here, but all of these talks are available for you to watch back on the AAIC platform. So if we tweak your interest or you missed any of those, you can go to, I think it's aaic.als.org, and you can watch the recordings of these. If you didn't register for the conference, you won't be able to watch those, I'm afraid, but we will do our best to summarize, to give you at least a sense of what they are. So that was Katerina Akassoglou, that's Akassoglou, from UCSF, who gave that talk. So
can I just jump in there quickly? Just to add about the sessions, I think that they are only available for 30 days after the conference. So if anybody wants to watch, then I think now would be the time to sort of go back and binge watch a couple of those series.
Jump on quickly. It's a shame. It'd be nice if they were more open released later on, but yeah, they were great. Thank you for that prompt. So segment 3, we're going to move on to talk about the plenary from Sharon Naismith, who was from the University of Sydney, who gave a plenary on the importance of sleep and mild cognitive impairment in Alzheimer's. And this time we've got Sherry. You're going to take a lead on this one.
Yes.
Thank you for so patient and waiting for your time.
Yep. So Sharon's plenary really highlights something crucial that we often overlook. That is the complexity of sleep. So sleep is not just about getting enough hours, right? As some of us may know, and also mentioned in her talk, sleep was not included in the last year's version of the recent Dementia Prevention Commission report. The multifaceted nature of sleep is the primary reason. So when we talk about sleep, we can talk about sleep quality and efficiency. We can talk about sleep disorder like obstructive sleep apnea. And we also have the entire physiological background of sleep, such as sleep oscillation, slow wave sleep, sleep spindle, and so on. So across multiple large cohort study and clinical investigation, she emphasized sleep as an early marker, not just a consequence of neurodegeneration, but potentially a contributor to it. The evidence is very strong. However, sleep is still under-recognized in routine clinical practice, particularly in memory clinics. By introducing work from their group on sleep spindle and memory consolidation, she reminds us that sleep is not simply rest, but an active process that supports brain plasticity and resilience. Sleep disturbances are linked to A-beta tau changes in the auric system and cognitive decline and overlight memory consolidation and so on. The good thing is that sleep problems are treatable. So for instance, CBTI and exercise can improve sleep quality. We also have new methods like bright light therapy that can also improve sleep, and also CPAP is effective for sleep apnea and may even protect cognition. However, as she suggested, we still need more work to test the effectiveness of these interventions on patients with dementia. And excitingly, new medications like dual orals and antagonists could improve sleep while also targeting Alzheimer's pathology. Yes, so that is a summary of the talk.
I'm interested. Did they? I didn't watch this talk. Did they? Did Sharon talk about the link to the glymphatic system as well? And because, of course, I mean, we've not known about the glymphatic system for that long, actually, have we? But that whole brain's dishwasher and how the clearance of things, was that part of this, or was it more practically on the clinical side?
It's also she didn't mention that much, but also it's part of it.
And do you think we're at the point where sleep interventions should be standard in a care pathway? Do you think, are we looking at it both post-diagnosis and, I guess, as part of that Lancet Commission on Risk Factors. Is there enough association now between people who really have terrible and rested sleep and the connections?
Well, that's a really important question. I think we're getting close, but we are not there yet. As someone who also works in this field, this plenary talk stands out to me as a challenge and opportunity in bridging the gap between research and implementation. We still need better screening tools, as the current tools that we have are not adapted the population. We need better both self-report and objective assessment of sleep. We need more data, particularly longitudinal data, and so on. There are not only methodology issues, but also crucial, necessary steps if we want to turn sleep science into effective dementia prevention and treatment strategies. We still have many questions to explore, such as how can we integrate sleep into a broader model of brain aging and dementia risk? How do we make sleep intervention available, scalable, and personalized? These questions will shape our field in the futures to come. I really hope we could see sleep included in the future Lancet Commission very soon.
I know, Ireneaus, you're going to talk to this as well, but so we talked about it's not just about its quality of sleep, not just how long you sleep for. What's the definition of quality sleep? So I know I can go away and try and get some more of that. Was that part of it? Do we know what defines a quality sleep?
Yeah, so regarding quality of sleep, we can have sleep duration and how many times you wake up during the whole night sleep and how many times you need to fall asleep, something like that. All these subscales of sleep quality.
Well, I have to confess, I'm a big fan of the afternoon nap. And I know that we talk a lot about the Mediterranean diet being important. And I know that a siesta is also something that's popular in that part of the world. So maybe it's a combination of an afternoon nap with a diet. I'm making jest, of course, but I don't know. I think, does anybody else? Is it only me that enjoys an afternoon nap? Nobody. You're all too busy, aren't you? You're all proper career academics. You're way too busy for afternoon nap. Anyway, thank you very much. So, Ireneaus, did you have anything to add to this one?
Yeah, actually, I mean, I think Sherry has done a great job at sort of summarizing everything. Then your question about sleep quality, I think there is a standard questionnaire on the Pittsburgh Sleep Quality Index, and then I think it does justice to that sleep quality question, where it contains subscales of sleep latency, sleep duration, sleep efficiency, and then some medications you take during sleep, and a whole lot of, I think it's 7 different subscales. Yeah, so I think it does a very good justice to it. And from the talk, I feel, let me refer to my notes right now. Okay, I think she made mention of 2 comparisons she did between participants who had slept and then those who hadn't slept, and then she found that participants who didn't really have enough sleep had a lesser representation of what she called low spindle fibers or waveforms, I think. So I think she measured using an EEG machine, and she found those waveforms that they are particularly, let me say, they are correlated or associated particularly with memory and cognition. And so in those participants who didn't have enough sleep, she realized that these waveforms were less represented in them, and then that affected their memory consolidation overnight as they consolidated the memory throughout the unit. Yeah, so I think sleep is actually a very good, it's a good factor we are actually looking at right now, which of course hasn't actually been looked at for quite a long time. Like the Lancet Commission didn't include it. And I think in 2002, the American Heart Association adopted sleep as part of their essential 8. At first it was 7, but then they added it to the Life Essential 8. So I think now it's gaining traction, and that's a good step. Yeah.
I wonder if I don't know. If I'm just thinking out loud, so do jump in about whether the benefits of kind of unnaturally induced sleep. Like we take statins to help. We know that statins help reduce cholesterol and other things. About whether those people that do have chronic sleep problems, if is medicated sleep or medication to help with sleep enough to offset the risk of not enough sleep, or is that the wrong kind of sleep? Did that come up?
Well, I don't think she mentioned anything concerning that, if my memory serves me right. But then I think sleep should be a natural sort of process of resting and then gaining the like you mentioned, the lymphatic system to actually wash the brain of its toxins and plaques that have already been built up. So I think depending on medications, it's actually not a good one, because I think she made mention of medications when she was talking about sleep, but I don't really quite remember that. But then I think she made some mention of that. But then I feel maybe going with CBT could be a better way of mitigating sleep related issues,
Yeah,
especially insomnia, than depending on drugs. Yeah.
And if lymphatic system is your thing, because it goes, I did look this up. I didn't have this memorized. We've only actually been describing the lymphatic system since 2012. That's how kind of new it is. But Ian Harrison from UCL, who is one of our regular contributors to podcasts and webinars and things, that's his area of research. So if that's something you're interested in, go look up Ian Harrison. We also have a sleep journal, a sleep and circadian rhythms journal club at Dementia Researchers. So if that's something you're interested in and you want to connect with others working in that field, drop me a line and we can connect you with our journal club. We're going to have to jump around.
Okay.
Sorry, go on.
About the lymphatics system, there's a recent paper using mice. They did direct massage to mice, and it increased the flow of lymphatics to the cervical lymph node. So in the future, there might be a massage machine where you can put it and then increase the A beta clearance from the brain.
Now you've got me interested. Whereabouts did it? Yeah, a massage machine. Where did it massage? Was it the head?
No, in the neck. So
okay.
their hypothesis it's known that the lymphatic system goes from the brain to the neck, and in the past we only knew the deep neck muscle lymph node. So for deep cervical lymph node, it's hard to intervene as a treatment target. So in this new paper in Science, they did a superficial neck lymph node with mice, of course, and then give direct stimulation, which is same as massage, and then it showed that that increased the flow of lymphatics to that lymph node.
Wow.
But they didn't do study with A beta, so it didn't show that it increased the A beta clearance, but it only showed the CSF flow.
It increases the flow. That's incredible. So do go look up that paper. We're going to have to jump around the program a little bit because some of our speakers have had some technical problems and haven't been able to join. We were next going to talk about Jill Livingston's talking about prevention, which we've done a few times already today, who gave a talk on prevention of dementia on a worldwide agenda. I'm going to put some of you on the spot here because I think most of you tick the box to say that you'd watched this and could talk to it. Would anybody like to have a little go at that? Unfortunately, we were going to have Nikita was going to talk to this, but Nikita's not here now. Anybody? Would you like to? No volunteers. That's okay. I'm putting you on the spot. Well, Jill Livingston is an incredible researcher at University College London, of course. Jill presented on dementia prevention as a global agenda. I mean, this is following on from their incredible work with the Lancet Commission report. That talk is available online. If Nikita manages to get back in here, we will pick up and we'll come back to that session. And also Juan Fortier gave a talk on Alzheimer's disease in Down syndrome, which was brilliant to see. I was so pleased to see Down syndrome and dementia take the big stage. It's all too often kind of small. So it's great to see this talk. Vita was going to talk to this one, and also Vita appears to be having technical problems. So we will try to come back to those. But if we don't cover those, do go away and have a look at the plenary talks sometime very soon, within the next few days. So let's move on to something we can talk about, which is Inhee Mook-Jung on gut-brain axis. And I believe Ireneaus, I think you were going to talk to this one. Inhee is from Seoul National University, on gut-brain axis. Take it away.
Yeah, I'll be talking to the gut-brain axis, and as Inhee Mook-Jung presented during the plenary session. So I think it was a nice session actually, and I clearly remember a lot because it was a 62nd birthday, so it was a lot of exciting moments. Yeah, so she introduced the gut-brain axis and then told us of the brain and then the gut being connected via two main tracts or two main routes. First one being the blood, and then the second one is the vagus nerve. And then the blood, as we know, getting to the brain, there was the blood-brain barrier, which makes the transport of substances across the brain and in the blood a little inhibitory. So, but then the vagus nerve has a direct physical link between the brain and the gut. It links the brain and the gut together, and that was exciting to know. And then she made mention of amyloid beta and then tau plaques, and then she mentioned because at first we were very confused as to okay, now there is plaque and then amyloid beta in the gut, and they're also present in the brain, but then which place do they start from, or do they originate from? So they did an experiment in mice, and then they found out that the amyloid plaques and then the beta the amyloid beta and then the tau plaques were originated in the colon of the mice. I think they realized that in the 11th month of development, and then in the 13th month of development, they found it to be present in the brain. So that gave a suggestion that probably these proteins originate from the gut, and then they are transported to the brain through the vagus nerve. And then she also texted I think about the APOE4 gene exposure, and then she at the end of I think the conclusion of that matter was that APOE4 I think fastens the transport of these proteins from the gut to the brain. And so participants with APOE4 were had more representation of these proteins in their brain as compared to those with E3, and that was exciting also. And then she mentioned also the lipoproteins that these bacteria produce. Of course, a lot of the bacteria in the gut are gram-negative bacteria, so they have this coating, the LPS coatings around their cell, and then that is actually what helps them to invade a lot of the to cause microbial attacks and then inflammatory attacks also. But then they realized these LPS are also present in the brain of AD patients, and so they try to establish the link between the gut microbiome and then the production of this LPS and its transport to the brain. And they found the culprit to be, of course, the vagus nerve, the sensory part of the vagus nerve transporting the proteins from, or the LPS in this case, from the gut to the brain. And so, and then I think one major thing she also mentioned, which actually caught my attention, was if the therapeutic means of getting or bypassing the blood-brain barrier, but then going by the means of the vagus nerve to transport drugs to transport drugs directly to the brain, so that we don't have less representation or less efficacy of drugs because of the BBB. And so that was also exciting too. So I think this gives a little summary of the gut-brain axis as she presented in the case of AD. Yeah.
That was really great summary. Thank you so much. Did you get a sense of how soon you think gut-brain research could be translated into clinical interventions?
Well, with that, I think, okay, with the discovery of the vagus nerve and then the visceral sensory nerve of the vagus nerve, which actually can be used to transport drugs directly to the brain and not through the BBB, I think researchers would have to start looking at that direction. I think it's like if we look at the nasal transport of drugs, for instance, where drugs are put directly into the nasal and then they get to the olfactory nerve directly to the brain, that could be one, as in side by side comparison of that pathway. So I think going by that route, that could be a little faster in clinical trials. But then the gut brain axis itself, or maybe the microbiome itself, is very specific for individuals. So we have differences in our gut microbiome, and of course there are some particular microbes that may be abundant all in all the gut, but then there are specifics that are different in each and every one, just like our genes maybe. So that would be a little difficult translating into clinical trials, but probably maybe 5 to 10 years that could be just a little time frame. Yeah.
It's an area
Can I
that
just jump?
Yeah, go ahead. See.
Sorry, no, I just want to jump in there and say that there's been quite a lot of studies that have tried to look at alternative routes besides the blood-brain barrier. And I think especially in the field of nanotechnology, of using like aerosol nanoparticles to, kind of spray up into the nose and, have its target therapy. But it's been quite difficult to actually, get the target right. But I think that this is, a field and an option that has been out there and that we're moving towards as well.
It's a whole area. Great to see that this new plays as well, because whenever we talk about gut, I think we seem to jump to talking about diet and plant-based diets and that connection, but actually looking at this in a new way is really refreshing. Sorry, Ireneaus, you were going to add to you.
Yeah, I was adding to what you were saying. I think that route is actually a promising one. Yeah, it's a promising one because I think there is no barrier in that direction, and then that could be a faster way of transmitting interventions. And then I think we would be able to see interventions to Parkinson's and AD and probably autism in those areas, and then very faster. Yeah,
absolutely.
Oh yeah. One more thing to add on. I had a chance to talk with another lab, and they're doing microbiome research and trying to develop a drug. Because in order to make drug and go into human trial is very long process and very hard, it's difficult to get in. So they're thinking of using making this microbiome drug as a supplement instead of drug. So it's easier to sell, easier to pass the regulations.
It is. Well, we've seen some of those. I mean, there are a few brands we've seen kicking around that have been very prominent. Some of the drinks and things, haven't they, over the years that look to do work in that space, which claim benefit. Let's move on. We've got how many more talks? We've only got the one last talk to summarize because of our missing guest. We're going to move on now for our final segment, summarizing the plenaries, to talk about Tony Wyss-Coray from Stanford, who presented on brain resilience in aging and neurodegeneration. And I think you're going to talk to this one. I hope. No? Did I make a mistake?
Yeah, but it's okay. I mean, I think I can just mention what I know about resilience. I think quite a lot of the points that we've been brought up today, sleep, are factors and contributors to something that we know as, cognitive reserve. And that's, education is also like one of the important, that helps people to maintain cognitive reserve. I think that when it comes to thinking about interventions for AD, this is then leading to, this multimodal approach where we are trying to, increase, education, reading, keeping your brain active and busy. And it just falls part of the, entire picture. I just don't think that there's one specific approach. But I mean, I think we've all seen also with the US Pointer study showing that multi-modal approaches also are quite helpful and maybe successful. Yeah, that's my spiel.
Did I make a mistake? Was somebody else due to talk to this, and I've stolen your opportunity? Or see, what was the talk you were going to summarize? Have I? I think you might be muted.
Sorry, everybody. It was the segment 1, biomarkers and clinical trajectories of preclinical AD.
Oh, the one that just sorry about that. My honestly, with so many plenary talks and so many speakers, I've clearly confused my program terribly. So I'm really sorry about that. Did anybody else see the Tony's talk on brain resilience?
Okay, yeah, you shall go.
Go on,
you first. What? Okay. Okay, then I start. Although I'm not directly working in this field, I'm very impressed by this effort they made to identify biomarkers. What strikes me most is the possibility of identifying brain resilience through blood-based signatures. So compare with infrastructure like PET scanner or like the invasive lumbar puncture for CSF collection, blood test sounds much more accessible and easier for patients, I think. And I wonder how widely these approaches are being implemented already. And also, another thing that really caught my attention was the idea that blood can be used to estimate the biological age of different organs, like the brain, the heart, or the immune system, and predict future disease risk. Honestly, I would also like to know my own brain age through such a blood test. So yes, from my own perspective, I wonder if we combine those blood-based biomarkers with some of our neuropsychological testing, maybe potentially help us achieve a much earlier and more accurate detection of dementia risk. Yeah, that is what I thought.
We should maybe talk about this. We've bought ourselves some time. We've got a little bit of extra time because of the slight shift in program, but we should so you all attended this year's AAIC online. I don't think you were there in person? You're all online. Did you come away with a view as to what you thought? What was the kind of really exciting areas right now? I mean, it feels like it's been fluid blood biomarkers for quite some time. I think that again came up through here, and the massive progress that's been made. In other years, it's been kind of big on microglia, or what do you think were the hot topics? What were the things you really enjoyed the most at this year's that got you excited, not necessarily from the plenaries?
I think so there were two things that really stood out to me the most when I was, overviewing the agenda and what everyone was going to be speaking about. And the first was that it seemed like there was more introduction or implementation of talks around neuropsychological testing, which has been quite a big conversation. I'm talking about screening tools, the efficiency of screening tools, and also including areas of the LMICs. I'm an LMIC researcher, and this is quite an important topic of conversation for me because we don't always have access to a full rounded clinical assessment in our hospitals. And this is something that's clearly lacking. So it's been quite amazing to see the conversations around, screening tools used for dementia. And then secondly was the sex difference sessions. It was incredible to see 6 different sessions talking about menopause and trying to, explore more, why do we see these sex differences? So those were the 2 things that I felt were, quite incredible. Of course, there were like smaller talks. I mean, there was a very interesting talk on like tunneling microtubules and the communication between microglia that I really enjoyed. But the overall theme was quite exciting. Yeah.
Sex and gender absolutely came up. I mean, that's the most prominent I've seen that. I mean, obviously it's there. There's been a peer for that, a professional interest area in ISTAART for some time, but it really rose to the top of the agenda in this AAIC, didn't it? Particularly, as you say, looking at menopause, but also as well on how we conduct research to make sure that we're more open to exploring those differences. And you mentioned about cognitive testing. Cultural sensitivity finally seems to have come in, and that we're not just expecting every country and different cultures and languages and things to just adopt the same, and that we're finally taking note of those cultural sensitivities to empower people to create robust tests that work for people. I guess, I mean, you mentioned at the start you're in South Africa. How do you use cognitive tests where you are? Have you had to adapt, or do you see adapted versions of those that used in different
settings? So I mean, quite importantly, it goes to the conversation of like Africa not being a monolith. There's multiple countries with multiple different cultural contexts. In our particular study, we've translated, we use a translated version, so we've adapted it by language, and tries to sort of stick to the construct of screening tools, but making it language appropriate and context appropriate for the people that we're going to be screening. We do know that it's largely based on education. A lot of people haven't necessarily used pen and paper, for example, for a very long time. So you come in and you ask them to, to draw a pentagram, for example. And we've been very, careful and sensitive about the cultural context that we are in, and knowing that like it might differ from the norms that have been set, in non-LMIC countries.
What about, I mean, you're all from different parts of the world. I mean, we've got a real global guest today. I don't know if you actually use cognitive assessments in your own work. How have you adapted locally? I'm pointing to the screen, which is useless.
Yeah, I think for me particularly, I've not really. I think I've just done one work with neuropsychological tools, but then over in Africa, I think there is this African neuropsychological battery, which comprises of the local proverbs that are present in the African continent or settings. So I think it's across Kenya, Uganda, Nigeria, across a few countries. So I think that is more representative of the people, and then their relationships, and also their experiences while living in Africa. And then, but I've not seen adapted tools from the West, from the Western world over in Africa. But then I think the African neuropsychological battery is a good representation of the dementia and then its registrations.
Well, I think those elements that need to be sensitive, because we're all now looking at how we combine biomarkers, aren't we? It's that kind of combination of cognitive assessments with fluid and with MRI and things, which we know are not available everywhere in the world. Xue-Rui, I think you were gonna add to that about were you gonna mention something about cognitive testing?
Yes, but I think sorry, I couldn't pronounce the name correctly. He already covered the part that I want to mention.
Okay.
Yeah.
So 2 hot topics there. Is there any other hot areas from across the AAIC anybody would like to mention, maybe from your own fields? Is there something you'd like to got you really excited or came out as a hot topic from the conference?
Yeah. Speaking of the cognitive resilience, I think there was a session on cognitive resilience alone, and it was particular. It stood out particularly to me because the speakers made me understand that cognitive resilience is not only the job of neurons alone, but then it's more or less like a heterogeneous work done by all the cells of the brain, the microglia, the neurons, and then the astrocytes also. And that gave a broader perspective on cognitive resilience. But then what stood out also was that education was not actually significant when it comes to cognitive resilience. But I feel a lot of work needs to be done, or more work needs to be done in that area, because in my mind, I'm thinking maybe when you stay in school for quite a long time, you should be more resilient cognitively. But then they didn't find any significance in there. So that was a little tricky then. Yeah.
Resilience prevention were high up there, and lots of sessions on those. What about in your field, Jin?
Oh, so for me, I think area was very interesting. One of the interesting topics, and there was a session by Dr. Demir group and Dr. Wilcock group, trying to understand area pathophysiology and the prevention drug for prevention of area. And in another session, I heard that Alzheimer's Association is preparing a new guideline, updated guideline for ARIA coming up this fall. So I'm really excited to learn more about it.
There's lots of ideas around at the moment, aren't they, about using complement therapies to go alongside some of those amyloid clearance medicines that to treat the symptoms. A little bit like, I guess we often refer back to HIV, don't we, about you had the treatment, but then you had the other things to deal with the side effects of those treatment. It's kind of that it's never one treatment. It'll be a combination of different things for individuals, and similarly to cancer, I guess, and ARIA being one of those kind of high risk areas at the moment that is getting attention. I think there were a couple of exhibitors in the stands as well that were using machine learning and AI to be able to look at scans and to be able to spot those on scans much earlier than traditionally we might have been able to catch them. Thank you, Jin, and Sherry. I'll give you a chance as well if there's anything particularly you want to mention.
Oh, well, for me, I really find the sleep and the brain resilience part are of interest for me. Like by watching the talk about brain resilience really make me wonder, like, because the speaker Tony show us like the resilience has molecular signature, so the plasticity protein, and this is the profile of the young brain, and sleep, as we know, like it's the one way that can clear the metabolic waste, which could support the somatic plasticity, and that is exactly what resilient brain are doing well. So it's made me wonder. So in this case, if we can, for example, use this biomarkers to test that and to identify the population with high risk, and monitoring their brain, their sleep, and maybe improve their sleep, would this help optimize the treatment procedure or something like that? That really makes me exciting.
Brilliant. Thank you very much. Again, really interesting areas. I haven't referred much to the live stream chat during our conversation, but we have had some chat in there and talking about adapting MMSE and ACE3, that they could be more tailored and involve carers potentially a little bit more as well. And then Some people talk about how they've been inspired to sign up to some studies as well. The Great Minds study, which is run out of, I think, at Oxford in the UK, and they do DNA sampling. Wherever you are in the world, if you're watching this and you're somebody living with dementia, or have a family member who's affected by this, there's always more opportunities for people to participate in studies. The recruitment to studies is always a massive challenge. So if you're watching the live stream and your family's been affected by this, in the UK, there's certainly a service called Join Dementia Research, which you can look at, that can connect you to trials. In the US, there's Trial Match. In Australia, there's Step Up. I think in many countries, there are local registers that will connect you to researchers that are looking for recruitment trials. And if there isn't one in your country, drop us a line and I'll help you find one, or connect you with people that might need your support to be involved in their research. I'm going to touch on one last little thing before we wrap up, which of course is, we mentioned at the start that you're all ISTAART ambassadors. I'd love to know practically what that means, to encourage maybe next year when the applications open again, others might want to follow in your footsteps. Z, what inspired you to join? How's your experience of an ISTAART ambassador so far?
It's been phenomenal, to be honest. I was new to the field of dementia research, and I really thought that this would have been a good way to make great connections, to learn from people that have more experience than me, and to also just serve the community in any way that I possibly could. And I've found that all of those things have come to fruition for me, and I wish I could join for another year.
Yeah, I think many people say that. Everybody who kind of comes off the program says how it's been great to connect and really build a community. I'm guessing it's a shame you couldn't get to the in-person part, but I'm assuming there'll be opportunities to be involved in some of the other AAIC events. There's some coming up out there. I think there's the Tau conference. You've got Neuroscience Next in February as well, some of their other events. Is there anybody else who would like to give a plug for ISTAART? What about you, Ireneaus?
Yeah, I think ISTAART is an exciting, let me say, organization that I think everyone should be encouraged to join. Of course, if you're interested in the brain and the neuroscience, I think it's an exciting platform everyone should join. Actually, I haven't been to any conference before, but then ISTAART has given me the opportunity to join not just a conference, but an international conference where, of course, learned a lot. I had been interested about in the brain for quite a long time, but then getting to the conference got me picked in the different areas that this research in brain is actually venturing into, and so kudos to the ISTAART team, and then to the I think
it truly is that global community, isn't it? I mean, even just on our, I think we've got 4 or 5 continents represented just on the live stream today, and the thing that's brought everybody together is that kind of ISTAART, which goes to show you it doesn't matter where in the world you are, or whether you're an undergraduate or a professor, that all of those. So for those who don't know, there are over 30 professional interest areas that essentially, it's kind of a club within a club, where ISTAART is the organization that brings everybody together, and it's free to join for students. And then they have professional interest areas that group people who have a particular common research interest, or not just by research, but by careers as well. There's the AWARE that looks at women in neuroscience, and ones that are particularly interested in patient participation, or the one that I started many years ago, which is called Peers, to help early career researchers to look at career challenges and mobilization and research culture and things. So if you're not already a member of ISTAART, go to istart.als.org, sign up for free if you're a student, and who knows, next year you could be one of the ISTAART ambassadors joining our brilliant audience here, and going along to AAIC and wearing a purple t-shirt, and then joining all the conference talks and getting involved in the peers along the way. I'm afraid that brings us to the end of our Plenary Plus. I'm going to say Plenary Plus reflections. Many thanks to to Z, Cherie, Ireneaus, and Jin, who've all been incredible. And apologies to our two guests who had technical difficulties, and Nikitha, who was definitely here at the start, and unfortunately I've had messages from hasn't been able to rejoin, and Vita as well, who also dropped in at the start and has had technical problems. We will do our best to make sure that they maybe could write something for us to share back the bits that we missed today. But thank you all very much for watching and listening. We'd love to hear your own thoughts on these talks, and so please do add comments into the chat or the post, or if you're watching this from recorded or listening to the podcast later, we'd love to hear your views as well. And finally, remember to mark your calendars for 2026, because the AAIC is coming to London, and it will be taking place from the 12th to the 16th of July. Abstracts, I don't want to assume. I think abstract submissions usually open later in the year. They're pretty early. You find out early on in the new year, so keep an eye out for those. And as we mentioned, early next year as well, there's usually an opportunity for you to apply to be an ISTAART ambassador, which comes with a great community, and these days as well, also with an added support program to really kind of create connections and build that community for early career researchers. Thank you very much all again. I'm Adam Smith. This has been a live recording of the Dementia Researcher podcast. So goodbye for now. Thank you.
Bye, everybody.